Good afternoon. We'll start. We're waiting for our last speaker, but I'm sure Lillian will show up in a few minutes. Welcome to this session, which is exploring the value proposition of enhanced recovery after surgery in bariatrics, and in particular its impact on ambulatory care. I know that people here in the audience are of two types: some who are very enthusiastic, and there are some who are a little bit skeptical and are here to sort of see if there is enough data to persuade them to consider ERAS. I have to be very frank, and I have to say I was one of the latters till about COVID, not because I didn't believe in early discharge, but I wasn't sure that any program is necessarily going to be better than what we do with most of our laparoscopic surgery. So I just sort of was very appropriate that I was chosen to chair this, because I had to bring together some of the people who are being enthusiastic about ERAS. So it also gave me a chance to sort of provide an overview of what enhanced recovery program is and how potentially it can have an impact on patient care and patient outcomes and even costs, and more importantly, an increasing number of outpatient bariatric procedures which are being done in countries where the value proposition makes sense. Again, this is very different because this is an international congress, and I know not in every country patients going home the same day or the next day is a priority. Whereas in North America, in some of the countries, it is a priority, and so it's an important area of discussion. Okay, these are our speakers. Can I have the first presentation? Okay, I have no conflict of interest regarding the material that I will present. As I said, my job this afternoon, is really to provide an overview. As you know, enhanced recovery is a multimodal perioperative care pathway, which was originally designed for open colorectal surgery. And it was in particular because they were trying to see if they can mimic similar shorter hospital stay that we were seeing with laparoscopic, believing that part of the advantage that minimally invasive surgery had brought was some of the changes in how we cared for a patient, the perioperative, no nasogastric tube, early mobilization, early discharge. And so the objectives of ERAS was to reduce the surgical stress, optimize the physiological function, around, particularly in the perioperative, enhance mobilization, reduce pain, and facilitate oral nutrition early. As I said, this was originally with colorectal, which was obviously an important aspect of that work, but it slowly has found ERAS pathways have been adopted to a number of other specialties, including bariatrics. So as I said, there are three components of any protocol, ERAS protocol. There's the preoperative, which is primarily optimization of the patient's medical condition, nutritional supplementation, cessation of alcohol and smoking as much as possible, some counseling, some limited fasting, and whether you believe in antibiotics or not, most include antibiotics. And an area which is really picked up is nausea prophylaxis, and with the use of some of the more powerful NK1 antagonists like aprepitant, this has become a very significant aspect of ERAS protocol. Intraoperatively, again, minimizing the use of narcotics in anesthesia, again, minimally invasive procedures, avoiding hypothermia, fluid euvolemia, and not overhydrating the patient, and strict glycemic control, and of course, no use of drains or oral or abdominal laparoscopically. And then immediate post-op, early mobilization and physical therapy, immediate pure nutrition, multimodal pain control, which includes, by the way, use of tap blocks intraoperatively or perioperatively, nausea prophylaxis, and early discharge with some form of support. So those are the various 3 aspects of the enhanced recovery programs, which, again, our speakers today will talk to in their own experience, how easy it is to. And I want to stress a few things from my perspective, because clearly the area which I find has been most helpful in moving from a regular bariatric to a more ERAS type, looking at discharging patients home the same day, has been preparing the patient preoperatively. So there is a certain expectations that they're going to go home. And certainly use of Aprepitant or some of the more powerful anti-nausea really minimizes nausea post-op. Use of tap blocks, from my perspective, was a very important aspect of minimizing use of narcotics during and after surgery, which again, and then preparing the patients for early mobilization. The moment you admit patients into the inpatient hospitals, it's almost a battle lost. You really want them to go to a dedicated area where they're mobilized early. The whole nursing team is configured around helping the patient be prepared for discharge. There have been significant amount of data coming out of the bariatric world around the world, and as you can see, the one distinguishing feature which has certainly been obviously important has been reduction in length of stay, which is almost universal. Some have reached statistical significance. Some the sample size was not large enough to reach the power. Reduction in complications and more importantly, readmission rates were really not that high. Obviously, the cost is beneficial, especially by minimizing the hospital stay, but also the other aspects of perioperative care of the patients if they're admitted into hospital. And then reduction in pain, early ambulation, and you can see mortality OR time, a few of them have shown some benefit, and then patient satisfaction, the ability to be able to go home to their own bed. Many of us who have become proponents of ERAS really were forced into this because of the COVID restrictions. Can I have a raise of hands? How many countries you could not do inpatient surgery for about 6 months during the COVID? That was a very common thing in many countries. However, our administrator said, if you can do the patient outpatient, you can go ahead. So many of us were actually forced into looking at outpatient procedures just because patients were clamoring for surgery. They could not have inpatient procedures. And really, we really were encouraged to look at ERAS protocols. And that's when, certainly in my own institution, we adopted, and it has certainly continued, and the benefits it's no going back because of this. And this is the length of stay. And not every one of my colleagues actually have adapted the sort of ambulatory care. They use the ERAS protocol, but they're not necessarily all of them sort of send their patients home the same day. But despite that, almost invariably everyone sends patients home the next day. This has certainly been a significant, this is in hours by the way, improvement in our length of stay. This is from our own hospital. And certainly when you look at pain control, the minimization of the use of dilaudid post-surgical and any narcotics, again, slightly increased use of anti-inflammatory medication or acetaminophen, but less dilaudid. And it's again, with the use of preoperative anti-nausea, more powerful anti-nausea, really reduced use of post-operative anti-nausea and less symptoms of nausea in these patients. So it really has made an impact in how patients feel immediate after surgery. Now, there are lots of data, and I'm sure our speakers will speak to that, but overall, you can see a decrease in length of stay, which, as I said, in some countries is an important important aspect because it directly affects the number of cases they can do, and that the hospitals they can manage the volumes of patients. And the average decrease in hospital stay of 1 to 2 days is quite common. But more importantly, studies have now also showed that there is potential improvement in some complications, both minor and major, because again, these patients are mobilized early, so less chance of some of the potential complications related to sedentary lifestyle, etc. So these are obviously not all of them are level 1 evidence, and I think more evidence needs to be garnered, and I think again our speakers today will talk about some of those aspects of it. Again, this is looking at readmission, which is one of the things that I was talking to somebody about this yesterday, and they were concerned that too many of their patients will come back, and would it really be beneficial to send the patients home only to admit? You will find that actually readmission rates are minimal. Clearly, there is a selection criteria. You're not going to send BMI 85 with a lot of comorbidities home the same day. So you do have to be smart about the patients who are you considering sending home on the same day. But at the same time, if you are selective and provide the type of care that these patients require, access to potential calling in, you'll find that the readmission rates are minimal. And you can see that this is, it's not a big issue that most centers, and again, our speakers today will talk about that. And finally, I know there is a talk about this, Dr. Cow is going to discuss this, but there is definite economic impact. For many countries like Canada, United States, and in European countries where cost of procedure is an important indicator for patients and the care facilities, the length of stay reduction is a major cost saving, and any amount saved will actually increase. In our own hospital, increases the resources available to do more patients as far as the surgery goes. And it's not just purely the cost of stay, but there are other aspects of the pharmacological costs, surgical material costs, and more importantly, complementary tests, etc., which add to the whole improvement in cost in patients who are under ERAS protocol. Not every patient with ERAS protocol actually goes home the same day, but they generally go home the next morning, and so does reduce the overall hospital stay. As a result of the experience with ERAS, as I said, many centers are now experimenting with sending increasing number of patients home the same day. And our next speaker will talk about his experience about this. This is a study which came out only this year in surgical endoscopy, looking at same-day discharge patients with sleeve and patients who were admitted. And again, the two groups were quite comparable. And what you see is that the rate of readmission for same-day discharge was no more than people who had admission after sleeve and went home the next day. And as far as reintervention was very similar. So no statistical significant. Again, going back to this argument that just sending home the same day does not mean you have a higher readmission rate. This is a study which, again, a very recent study which came out a few years ago, which looks at the number of patients done, almost 3,000 patients done as an outpatient sleeve gastrectomies in the United States. Again, very few, 7 out of 3,000 patients had to be admitted after surgery. So most patients were able to be completed and sent home following the surgery. Now, of course, there was some selection criteria which went on in selecting these patients, but still showing that when you plan an outpatient procedure, majority of patients can still go home the same day without a need for transfer. This is a cohort of 500 patients in Europe who underwent bypass, and the plan was to send them home the same day. Again, you can see the BMI, average BMI 42, some ASA 3 patients in this group of patients who were planned to be going home the same day after bypass. And again, 93% were able to go home the same day. So of those patients who were planning to go home the same day, majority were successfully discharged the same day. So really the ERAS protocol has allowed people to consider ambulatory bariatric surgery as a mainstay of their post-operative care. And I think it's a very, opens a new chapter. In my own institution, we are actually now sending patients home after duodenal switches, particularly second stage duodenal, two-stage duodenal switch, home the same day. And again, these patients do very well. So it's not a matter of what operation, only sleeve, but certainly bypass and DSs can go home the same day. So in summary, I'm now a believer that enhanced recovery after surgery in bariatric surgery is associated with shorter length of stay. Many patients can be discharged on the same day if they meet the correct criteria. And again, I'll let our speakers to talk about that, because I'm sure they all have their own pearls of wisdom, how to select the patient. There's definitely reduced nausea and postoperative pain associated with the ERAS protocol. And I think if you really look at the cost, and if it is an important indicator in your healthcare delivery system, certainly it's associated with reduction in cost to the system as well as to the patient. And there's really no major increase in readmission and complication, which is the one factor which I think frightens people in choosing to follow an ERAS protocol. So I have to say, as somebody who a few years ago was not a big believer in ERAS, I'm now a strong believer, and I do believe that it is a big factor why many of the studies that have been presented to this point have shown over the last few years there's been a reduction in mortality, morbidity, and the length of hospital stay. And it's not just that we are doing the surgeries better, it's really how we're looking after patients perioperatively better. And I think that's a big factor. Thank you very much.
Thank you very much for a very nice review. So we can say one of the benefits of COVID is ERAS. Like everything in life.
Increased adoption of ERAS. Yeah.
Everything in life has a benefit. So it's my pleasure to introduce the next speaker, who will continue in the same line, Dr. Pierre Garnier from Montreal, and who will talk about ambulatory bariatric consideration beyond the sleeve gastrectomy, because ERAS was connected, as Dr. Anvari said earlier, to the sleeve gastrectomy patients, and now we want to extend that to other bariatric procedures. So Dr. Garnier will tell us about the other consideration beyond vertical sleeve gastrectomy.
Thank you very much for giving me the opportunity to present our experience with day surgery. This is my conflict of interest slide. I think nothing will be interfered with the presentation. Let's start with what is the fear of ambulatory surgery and bariatric surgery itself? It's probably from all the literature about bariatric surgery itself. As you know, bariatric surgery is there since like 40 years ago. And if we look at some study, this is an example from Di Maria, 2007, looking at 2,000 patients on the prospective data. And that study was done looking at patients having a surgery between 1995 and 2004. And the main goal for that study from Dr. Di Maria was to look at the risk factor associated with complication and mortality for surgery. And he emphasized the fact that, any patient with BMI over 50, male gender, hypertension, risk of PA, or age over 45 increase the risk of a bariatric surgery. But come on, we are bariatric surgeons. Most of our patients have high blood pressure, BMI over 50 or around 50. And this is a problem. And he proved that if you had those risk factors, example, if you have 0 risk factor, mortality rate will be 0. Okay? But as you increase the amount of risk factor, if you go up to 5 comorbidity at the same time, 16% of mortality. For me, that doesn't make sense, but that was the whole literature, okay? And probably this thing had a huge impact on the perception of the safety of bariatric surgery. But what was the evolution of bariatric surgery? As you know, during the evolution of bariatric surgery, everything has switched from open surgery to laparoscopy surgery. This is an interesting paper in Annals of Surgery 2020, looking at the evolution of bariatric surgery from 1993 to 2016, shown a real decrease in complication rate. And if you look at the mortality rate, that was massive reduction of mortality. And as you remember, at the early 2010, the band surgery was around the corner, and a lot of surgeons have jumping from open surgery to band surgery, and many surgeons was using band as an alternative and as well as a day surgery. But for today, I'm not going to talk about band surgery because most of the surgeons, I think, don't do any more band, and I think now we need to think further. I think Maren did a great presentation about ERAS. I'm not going to pass through all the concept, but one of the most important things for us as a bariatric surgeon is the reason why a patient stays longer in hospital. The two main reasons are pain and nausea. 50% of your patient will stay longer than expected for those two problems, okay? Weakness in organization for transfer, whatever the reason why, but this is the main reason. And our service, 2012, we decided to start sleeve gastrectomy as a day surgery. And this is our first paper looking at our first 328 patients from August 2012 to February 2015. During that period of time, we did close to 1,000 sleeves, but 1/3 of those sleeves has been done as a day surgery. And we have been very strict at the beginning with our exclusion criteria. And any patient over 55, BMI over 55, or any patient who receiving insulin were excluded from the project, from the study, sorry. And if you look at the demographic of the patient, half of the patient came with comorbidity, but it's normal. We operate on obese patients. Those patients come with like type 2 diabetes, high blood pressure. And I'm not going to pass all with our protocol because if you want it, I could give you. But look at this. If you remember what Maren presented about ERAS, it's all about the same. We need to pay attention. All the pre-op phase. Anything we give during the surgery is very important, and everything you're going to pay, everything you're going to do or give at the patient after surgery will pay. That's for sure. And for us, I think the PACU modified criteria is probably one of the most important things because, on a regular day of surgery, you transfer your patient to the floor. You don't pay not much attention, but you need to understand that our patient go home. And that's for that reason, the pain control need to be perfect. Conscientiousness of the patient should be perfect, and oxygenation as well. That was our three main target to send patient home. If you look at the raw data, the length of stay was 8 hours. That was from the arrival to the departure of the patient. Overnight hospitalization, 1.8%. The decision was made in the PACU from the surgeon because the surgeon was not feeling confident to sending the patient home. And that was, even if we try to do a day surgery, if you don't feel comfortable for whatever the reason, we keep the patient in hospital, okay? And but the readmission rate at that time was 8.5%. And if you look at the reason why a patient came back to the emergency, as you could imagine, same problem, nausea and abdominal pain. If you look at the major complication, honestly, day surgery don't affect complication. Yeah, we had leak. 2 patients over 328 patients had leak. For me, it's not the fact that we do day surgery. We had 1 patient who had intra-abdominal bleeding. I know that a lot of surgeons are worried about bleeding, okay? But honestly, bleeding occurs most of the time in a few hours after the surgery. It's kind of impossible to having a patient coming back 3 days after the surgery with acute bleeding. Doesn't make sense, okay? And after that, we did a second survey because I did another work on neuromuscular block and quality patient recovery. That was in the same area, 2015, looking at only 50 patients, but that was a prospective study. And you will see same target patient, but more sleep apnea. Why? Because at the beginning, we've been a little bit worried about having a day surgery on an obese patient with a sleep apnea. But after many years, we realized that a sleep apnea was not a contraindication, and this is the reason why, for the second study, we found more patients with sleep apnea. We found an interesting situation where most of our patients were not in deep neuromuscular block during the surgery. And this aspect of the anesthesiology, you're not control this part, as you know. You trust your anesthesiologist, but they make an impact on your surgery. This is an example. All our patients in deep neuromuscular block had a faster surgery, less event during the surgery, and even in the recovery room, they were using less narcotic, less pain. This is very important, And, it's a teamwork. Dr. Maron presented a nice presentation on ERAS, but it's all about the teamwork. You need to prep the patient before the surgery, to prep your team during the surgery, and pay attention to the patient after the surgery. And we realize as well that women complain of more nausea, especially if they're young. And look at your program. The first patient of your program is always the whole man, And the youngest woman is always at the end of the day. But doesn't make sense because those patients have more nausea, and it will have an impact if you want to discharge those patients. You need to think about it when you program your schedule. And here, result, no overnight hospitalization, no readmission on those 50 patients. And the only reason is because all of the team knew at that time that I was realizing a prospective study. That means everybody was focusing on providing the best care to the patient. And we see that if everybody are focused on the care of the patient, we could reach a magnificent result. But what's next after doing more than maybe 4,000 sleeve as a day surgery? Because we started the program in 2012. As you know, patient going to come back, revision surgery, weight regain, reflux, and those patients had a day surgery, most of them, and they don't want to stay in the hospital for the next surgery. And what is the next surgery? Most of the next step will be anastomotic surgery. And at that time, that was a period where the COVID hit the planet, and we already decided, this is the time to do it. And this is the third paper we did, and I think we started a little bit strong with robotic SADI as a day surgery. We said, why not? Because that was a revisional surgery, a lot of experience with SADI and BPDDS, a lot of experience with robotic surgery, and we say, go on. If you look at the demography of the patient, we started a study in 2021, mean age, 40, mostly female. And if you look at the median time after sleeve, a little bit more than 4 years. Surgery, robotic SADI, is around 2 hours, skin to skin. If you look at the criteria, we're still keeping the same criteria as in the beginning. We haven't changed that. We're a little bit more severe with the robotic SADI. Just try to avoid any complex abdominal surgery to prevent any difficulties during the surgery. And we were a little bit more aware about the BMI for those type of for this type of surgery. And if you look at the bariatric history, some patients had band surgery before plication. And one of the interesting things, 1/3 of the patient never had a day surgery before. But 2/3 of this patient had a sleeve as a day surgery. And for them, that was normal to offer the next step as a day surgery. There's no issue about that. Here, this is our protocol, same thing. If somebody wants to share, I could share the information with anybody. It's not and it's exactly the same type of protocol we have since the beginning. And if you look at the complication rate, most of the time, patient going to come back for abdominal pain. And yes, with SADI, sadly, sometimes we have a leak or maybe hematoma. And honestly, it's not about the fact that we do it as a day surgery, it's the consequence of doing surgery. And finally, this is our last paper, just published last month in the Source. We are looking at all the anastomotic metabolic bariatric surgery, looking at the 30-day outcomes. And if you look at the time frame exactly during the COVID, April 21 to November 23, We did 208 patients, mostly female. 3/4 of those patients had a previous sleeve gastrectomy, a mean BMI of 42, mean age 41. If you look at the data, most of them had SADI. 92 has a SADI, 72 has a Roux-en-Y gastric bypass, 35 has OAGB, and 9 patients had a SASI. Most of them revisional surgery, most of them robotic surgery. More than 20% had a hiatal hernia repair at the same time. But if you look at the data, look at the overnight stay, the variation was between 1.4 to 5.5. If you look at the readmission rate, between 3% to 7%. Are we surprised of that? It's a little bit higher than sleeve? No, because the surgery is longer, okay? And we found in the previous study, we know that our patients are not totally in deep neuromuscular block, the pain control are not perfect in those kind of patients, but at least we could achieve good result, and as mentioned previously, complication like leak, hematoma, or bowel obstruction there's no relation with day surgery. It's common complication from surgery. And they highlight on the Source magazine saying that the strategy is focusing on an early outcome, and we have to be very strict with the protocol. That's for sure. I think we need experience. I don't think it's a good idea to start your practice doing day surgery. I think you need experience, make sure that you control a lot of information, a lot of data before trying to do day surgery. That's for sure. And what about new concept? First thing, the abdominal pressure. Since many years, since the beginning, I remember when I was a resident, when you were starting your laparoscopy, you put the machine, the insufflation at 15. Probably most of you put the machine at 15, okay? But 15 is not the best pressure to improve the quality care, because there's several studies on gallbladder surgery showing that there's a clear advantage to decrease the intra-abdominal pressure. And as you see here, you could decrease by 50% the chance of having shoulder pain, okay? Just by decreasing the pressure from 15 to under 10. And for me, sleeve gastrectomy or gallbladder surgery looks similar, okay? 4 trocar, 5 trocar, we resect the tissue, same thing, okay? We need to focus on that. And I think Marianne already talked about the tab block. For us, it's a game changer with the fact that our new anesthesiologists like to do it with the ultrasound. Some of the patients receive the tab block before the surgery. Some patients receive after the surgery, but it's a game changer because we need to decrease the pain if you want to avoid readmission. In conclusion, for me, ambulatory bariatric surgery is safe, secure, and selected patient, even for the surgery with anastomosis. Young women require more anti-nausea drug. We need to lower the abdominal pressure if it's feasible. Yeah, we know. We operate on obese patients. Sometimes it's not easy, but honestly, for a regular sleeve, you are able to decrease the abdominal pressure. And I think the tab block is the future to improve the pain control. Thank you very much.
Thank you very much, Pierre. I know you may have questions, but we've got an ample amount of time at the end for conversations and discussions, including whether the tap lock needs to be done by the anesthetist or the surgeons. Certainly in our institution, the surgeons do the tap lock just at the beginning of the procedure. Our next speaker is Dr. Ramji. Dr. Ramji is going to talk about really some of the challenges in setting up ERAS. He certainly went through that in our institution, and also the increasing applications of the newer IT technologies which can sort of assist in that process. So, Karim, thank you.
Great, thank you. Thanks, Dr. Bari, and thank you, everyone. Thanks, Dr. El-Haddad and Dr. Garneau for some interesting insights out of Montreal. I, too, have a real passion for effective delivery of care, particularly in bariatric patients, and how to optimize that in a unique way. Now, what we've done today is look at the 10,000-foot level, and today what I want to, in my few minutes, show you what it was like at the ground level on building a same-day discharge program in our province of Ontario at the largest bariatric center in Ontario, and what that specific experience was like. Let's see here. Perfect. I have no conflicts of interest. Is it this one? Okay, perfect. Now, you'll see very clearly today that we established that the major claim for ERAS has been to standardize postoperative care, accelerate recovery, and as a notable byproduct, we've been able to see a decrease in inpatient resources. And from our perspective, when we added bariatric ERAS at our institution, we had great success in moving the length of stay from 2.2 days down to about 1.4 days. And then spurred by the lack of resources that continued well beyond the COVID era, and looking at private ambulatory centers as well as institutions throughout the United States that had great success with ambulatory programs, we asked ourselves the same question, that equipped with stringent selection criteria, multimodal pharmacotherapeutics, and an infrastructure that allows for close follow-up and supportive measures, could we ourselves operationalize a same-day pathway specifically for Roux-en-Y gastric bypass patients? Now, the central focus behind this always has to come at patient selection. And so we built kind of a robust selection process as our first measure into starting a program of this nature. That started with a pre-procedure selection process that came from the surgical consent appointment, then an intraoperative eligibility criteria, and then a same-day discharge criteria. And patients would have to qualify for all three in order to then qualify for same-day discharge. If they fell off at any point, they would fall into our same-day or our standard bariatric ERAS pathway, where they'd be discharged the following morning, usually at 10 o'clock the next morning. What that ultimately meant is that we were picking lower risk patients and patients that had no comorbidities that required close monitor. We were looking at lower risk procedures, so index procedures that did not have additional hiatal hernia repairs, removal of lap bands, cholecystectomies. We were looking at the most simple index Roux-en-Y gastric bypass with no unexpected intraoperative events. And then we're not compromising on discharge criteria. In fact, we're even more stringent. And so we would maintain the same discharge criteria that would be for anybody leaving on post-op day 1 or day 2. When we look at the highlights of our pathway, some of the important medications that I think are critical to, as Dr. Anvari mentioned, a set of pharmacotherapeutics that have allowed for early discharge. Aprepitant has been a significant game changer for us. The antiemetic has basically potentiated the impact of drugs like ondansetron and dexamethasone. And we give this preoperatively, and very well can continue to give this in the postoperative state, as some do in many programs. We added tranexamic acid, either between 1 to 2 grams, depending on the patient. We also spoke to our acute pain physicians that were involved as we were in the middle of an opioid reduction pathway at our institution, even considering opioid elimination, and ultimately the concept of rational opioid use came to play, where we decided that we would create a protocol that would allow for lower doses of opiates to be used and more regular follow-up from nursing in order to minimize the use of opioids. And that proved actually quite effective. Discharge, we would give a broad set of antiemetics and analgesics. One of the first barriers that came onto us as we introduced this to our department was from our acute care surgical department. And there was concern of readmission rates that would occur in discharging bypass patients the immediate post-op day 0. And what that led us to do is, as we looked into the literature, we found that the complication rate for major complications, as Dr. Garneau has shown, is less than 1%, but the readmission rate can sometimes be between 3 to 4% on historical papers. What that ultimately led us to do is to create multiple pathways, both for day hours and for afternight, in order to give people some guidance on what kind of follow-up was necessary. So during the day, our nurse practitioners would help manage any patients that would come to hospital. And then post-operatively, if there were any red flags, a bariatric surgeon would be contacted. Otherwise, the acute care surgery team would help manage this. And this well-warranted level of concern helped us establish and build these separate pathways. Now, this is all in well and good, and how did we ultimately perform? We've now to date done about triple to quadruple the numbers here, but I wanted to show you our early data because this is what informed a lot of our future decisions. And as you can see from the left part of the graph, you can see we've inevitably selected patients compared to our regular population that have a lower risk profile than all comers. Interestingly enough, similar to Dr. Garneau's experience, most of our patients in our bypass group were discharged about 8.5 hours post surgery, and that could be anywhere between 5 to 13 hours. For any of the same day discharge patients, we would do them as the first or second case in the day in order to have the maximum of time before they need to be admitted overnight. We also noticed Sugamidex was more commonly used. We don't use it broadly in our bariatric patients, but we are currently in the midst of having a discussion with our anesthesia colleagues on a much more distinct pathway that is done primarily for bariatric anesthesia. If you think about a patient being discharged, within 8.5 hours, that 1 hour under anesthetic is such a significant portion of the time that they're receiving medical care. It makes sense to have a protocol before, during the operation, and after. And so now we are in the process of building a clear pathway for using drugs like Sugamidex, where we give deep neuromuscular blockade and then reverse it very clearly in a much more significant way. Interesting enough, when the patients went to the ward, when we compared patients that were done or were discharged on post-op day 0 and post-op day 1, you'll see that we noticed that the patients that were discharged a little later had higher requirements of hydromorphone, higher requirements of ondansetron, and higher fluid needs. Now the question is, and it begs to question, were these patients over-medicated, or in fact did they select themselves out for same-day discharge and just intrinsically had more requirements and therefore weren't good candidates for a same-day discharge pathway? When we look at 30-day outcomes, we had no complications in terms of patients in that 30-day group, and we had no readmissions to hospital from that group that was discharged same day. When we zoom in on the patients that were not able to be discharged that same day, out of the 16 patients in that group, 15 out of the 16 of them were discharged the following morning at 10 a.m. And very similar again to Dr. Garneau's experience, residual postoperative pain was common. Nausea, urinary retention, patient anxiety, apprehension was a factor, and inadequate oral intake. And so we were conscious of those factors. So as we now step back and look at all of this data that we were able to generate and our experience in that process, I'll take a couple moments to go through the perioperative, surgical, and administrative pain points, challenges, insights that we were able to take from this experience. And this was highlighted previously by Dr. Anvari and Dr. Garneau, that without question, the central point of success comes from patient expectation management. Before we started our bariatric ERAS program, patients would be in hospital after a bypass for 3 to 4 days. After bariatric ERAS, we're down to about 1.4 days. And then after same day, they're being discharged about 8.5 hours after surgery. The surgery has not changed. The technique has not changed. The surgeons have not changed. The pharmacological interventions have been helpful, but patient expectation management is paramount to that process. But what's uniquely more important is that there are so many touch points in a bariatric program that are beyond the surgeon themselves. That includes the nurse practitioners, the dietitians, the nurses before and after. And so we did a number of lunch and learns in order to reiterate what this process looked like, because if that anxiety exists among the healthcare worker, it will trickle down to the patient. And so that proved to be very successful, where patients were excited to be potentially discharged same day. And if they didn't qualify, that was okay. They're ready to be discharged the following morning. And I think Dr. Garneau's point about patients that had previously had a same-day case were then motivated for another same-day case in upcoming revisional surgeries, if so be it. Obviously, multimodal analgesia and and pre-medication was a big factor for anti-nauseants. We've now been pushing to get aprepitant on formulary, but in this current state, patients will pay out of pocket to get a dose of aprepitant in our Canadian system before we can get it on formulary. From a surgical standpoint, this was very interesting. The group practice with 5 bariatric surgeons has been challenging over the many years to get concordance between practice patterns in the postoperative state. Bariatric ERAS was one step to get them there, and then same-day discharge hasn't been uptaken across the board among all the surgeons, and that's very much expected. There are different levels of risk tolerance among a group, but what we have noticed is that over time, as the data starts to become more and more reassuring, we have more surgeons that are interested in considering that for a subset of patients. We are now, as I explained earlier, that we are looking at building a protocol specifically, and I can see that they've done that in Montreal, for anesthesia protocol, because there's a great deal of variability that exists there in terms of narcotics, anti-nauseants, and use of Sigamadex. And then finally, administrative. It fascinates me that until you start talking about administrative challenges, the medical stuff seems so simple after all. But it's the administrative stuff that starts to give you some chest pain. But interestingly enough, what we found, the initial pushback that we had from our ACS department helped us re-innovate. And so we welcome that kind of dissent and those kind of ideas, because it allows us to innovate around better protocols, a better supportive platform, so that there's a right safety network for these patients once they are discharged. The second issue, and Dr. Anvari highlighted that to some degree, is that there is such a huge difference between an ambulatory focus center and an inpatient department. And when we first started the program, which was somewhat in the middle of COVID, we had an ambulatory center. And the nature of nursing care that was provided was of that ambulatory vision of sorts. And so patients saw people being discharged the same day. It engendered some confidence. The nurses knew that patients would be getting up early, that type of thing. And there's no amount of lunch and learns that can exchange for the fact that when patients go to a regular surgical ward where there are colorectal patients and foregut patients that are staying longer, that same type of mindset is lost. And so the environment is so impactful on what our success was. The final piece that has been challenging for us at this stage is that when we're not entirely sure which patients are going to be discharged until later in the day, a lot of these patients have already been earmarked a bed from the inpatient ward. And so the cost benefits is sometimes lost because they've already been devoted that bed for overnight. And so we're working on better ways to predict which patients are going to be much more successful in that respect. Some of the next steps in discharging these patients and having some confidence with that is also looking at wearable technologies that will allow us to extend our monitoring to these patients post-operatively, and then also to automate a lot of the steps in terms of checking in on patients regularly and having them provide us with some feedback so that we know that, if a patient is not discharged on day 0, that's not a failure of the program. It's a failure if they go home, have an adverse event, and don't come back to hospital. And so using technology to help manage that process is what we're able to do. And so at the end of the day, what we were able to demonstrate is that through stringent patient selection, multimodal pharmacotherapeutics, and close follow-up, and most importantly, a supportive infrastructure around it, we were able to demonstrate that for sure a same-day program for Roux-en-Y gastric bypass is possible. The only challenge is with low numbers, we can't ensure that we have safety at that stage or the impact of the burden on our ACS program, but we continue to try to minimize pain points and maximize how we want to optimize this for our patients. So thank you very much.